Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome to Perspective with me, Julie Ali. And on the show today, we're going to be talking with Dr. Angelique Coetzee. She's a general practitioner. She also serves on the board at SAMA. She will tell us what exactly it is that she does there. But she's in studio today to talk to us about something controversial. She will either correct me when I use the word controversial. It may or may not be controversial. We're going to be talking about the drug Ozempic, which very many people are using it as a weight loss drug. It's a drug to control diabetes, but we believe that a lot of people are using it for weight loss, and there's a new terminology attached to the drug Ozempic, and it's called Ozempic face. So all of that will be covered on the show this morning with Dr. Angelique Coetzee. Good morning, wonderful to have you once again.
Good morning, Julie, and it's always nice to be on your show. It's an honor, it's my honor to be here.
Thank you so very much. When I spoke with you last, approximately 6 months ago or longer, you indicated that you're going to be serving on the board, or you're going to be doing some work with SAMA, which is the South African Medical Association. What exactly is it that you're doing there?
So, currently, I'm not on the main board. I am on the General Practitioners Committee, as well as on the Finance Committee of SAMA. Incidentally, we just had a finance meeting last night, so that's my role, and I'm also on my branch's committee that serve my branch. So that's the three roles that I currently play in the SAMA.
And this is all in addition to your work as a general practitioner?
Yes. Unfortunately, I can't see myself as anywhere else as being a GP. So I love family medicine. I love the interactions at primary healthcare. And it's a very challenging field. I think it's much more challenging than becoming a specialist, because you need to be aware of nearly everything. You're not confined to just a certain area of medicine. It's like you need to know everything. From a little pimple to whatever happened at home. So that's actually my first love. I'm also part of what we are calling the Unity Forum of Family Practitioners. So we around about during COVID, we actually started to form this forum. And that includes the SAMA, it includes all the IPAs and various other doctor organizations out there. We try to bring them under one umbrella, so that when you need to negotiate with your medical schemes or with government or whoever is relevant in the healthcare sector, you then start to negotiate with the UFFP, and my chair is Dr. Unban Pillay, and I'm the vice chair. So we try to at that level, to influence primary healthcare.
I may have asked you this question in a previous interview, but I'm going to bring it up again, and it's the cost of healthcare services. Now, we also, with due respect, realize that people who specialize, it takes them many years and it's costly for them to specialize. When you go to a doctor's rooms, you know that the overheads are very, very high. They've got staff, they've got other overheads, holds lots of medical equipment that they need to have available to service their patients. But you also find that it comes at a cost, and a lot of doctors ask you to sign a disclaimer that even though they charge 500%, possibly more than the medical aid rates, you agree to pay that because you're a patient, you're desperate, you need the medical support and services. Is SAMA in agreement with those type of disclaimers, and is it justified? And perhaps I'm being a bit unfair, because I've engaged with a couple of professionals or specialists, and they give you the utmost care, and they really are focused on their niche speciality. So you do know that you're in very good hands. But I sometimes find that the pricing can be out of reach of ordinary working class people.
Julie, you actually touched on a very important aspect of or component of the current healthcare system. So first of all, I need to clarify that if you look at the health cost in South Africa and you compare it to the costs in some of the other first world countries, we're not that far or that much higher. What we see is that a lot of people from the UK, Australia, and New Zealand or Canada, when they're sick, they will come back to South Africa to get some specialist care here because it's more affordable. So I think we just need to understand that as well. So when we look at, and I can speak on behalf of the GPs, so when we look at the current fee for the GPs that we are getting, the fees is not kept track with inflation. Everything is going up, and our increases, when the medical scheme increases their contribute or the patient's contributions, some of them are 10% or so. We don't get that. If you look at the Council of Medical Schemes, you will see that the GPs as well as the dentist are getting less than 5 cents out of every rand. So we are really, really at the bottom line. So now you're sitting with doctors at the primary healthcare level, and you are practicing in a rural area. There is not a lot of income. People are poor. So you bring down your costs. Then you have to, unfortunately, to run feet so that you can make your overheads get paid. I'm always saying, if I go to Pick n Pay and I say, listen, I see the poor, give me a bread because I see the poor, they will think I'm mad. I have to pay. So unfortunately, you will have then that increased fee. With the increased fee, and the fact that, and this is also what we're seeing in the public sector, the increased fee as well as the lack of monies, you then start not to give good care to the patient because there's not actually monies available for that. Then you will get GPs that works in the Sandton area, and they can afford to tell the patients, I do not take your medical scheme. But there's a lot of money around. And then you get GPs like me who works in the middle class area. I promise you, we take the medical schemes because we know that the average person out there is really suffering. Does it help us to make ends meet? It's a nightmare for us. What is one of the biggest nightmares is the every second month VAT that you have to pay. I don't think people understand that we also pay VAT every second month. It is a huge impact on our cash flow. But if you then look at the specialists, yes, we get good care from the specialists, but we also need to understand that a lot of people jump the GP and go straight to the specialist, while they could have gotten that care cheaper at the GP level. So you need to choose your GP. You need to make sure that your GP can actually do a pap smear, can actually do an ECG, and can look and listen and touch you so that you don't need to go to a specialist. Also remember...
Can I interrupt you there and tell you why a lot of people jump the GP? The thinking is, I don't have to pay Dr. Angelique the consult fee of maybe 500 or 600 rands when she is still going to refer me on to a specialist. So I'll put that 600 rand into my pocket and just go directly through to the specialist. Do you think that that is unethical? Do you believe that patients should go via their GP so that he or she can understand their case history and make sure they're referred on to the right specialist?
I fully agree with you on that one. So, if you choose your GP, I'm always saying you get a 5-minute GP and then you get a 15, 20-minute GP. Choose your 20-minute GP if you are older, because that GP will spend some time with you and listen to your complaints. Your 5-minute GP, the amount of time, you can't do anything for a patient really in 5 minutes. So if you are young and you don't want to listen or don't want a proper examination, go to a 5-minute GP. But the older you get, you need to start to choose your GP. You need to trust your GP, and the GP needs to trust you as well. It's a trust goes both ways. Because if I'm asking you, how are you feeling, and you don't tell me, I went to casualty last week, how would I know you were at casualty? So I need to be the care or the gatekeeper and make sure. So that would also place a responsibility on the GPs to start doing their work better and not just be a 5-minute GP.
Okay, the reason you're here is we're going to be talking about the controversial drug Ozempic, but we will get to that, which is really the heart of this conversation today. We'll get to it right after the break. Dr. Angelique Coetzee is a GP. She's based in Tshwane, and she's here to talk to us about, like I've said, the controversial drug. She may disagree with me, but let's get to her after the break and get her input on the discussion at hand, and that, of course, is Ozempic. Welcome back. I'm delighted to have in studio today Dr. Angelique Coetzee. She's a GP. She comes from Tshwane in Pretoria, and she is here to talk to us about the controversy around the drug called Ozempic. So let's get talking. It's being referred to as Ozempic face. What are they trying to say there? Question number one. And Ozempic actually is a drug to treat diabetes. But somewhere along the line over the past few years, people have cottoned on to the fact that when you're on this drug, it enables you to lose lots of weight. So people who have desperately tried to lose weight over a long period of time, have tried every diet under the sun, just not successful, have now turned to Ozempic. So we need to understand the pros and cons of Ozempic, and why is it now being referred to as Ozempic face?
Yeah, that's a mouthful. Let me first start with to try to explain to patients how Ozempic or semaglutide is working. How did we get to that? So it is working. Also, yeah, let me first start on it's a GLP-1 agonist. So it works on the GLP levels in the body. The second
GLP being gamma what?
Gamma leptin. I don't have the whole. We're so used to the GLP abbreviation, but what it does, it increases your incretins. That is a hormone that is normally produced while you are eating by the stomach. So it increases that incretin hormone. It makes you feel full much easier. It also delay the passage of the food, so you feel full. Okay. Then it also help the liver not to release so much glucose, and also increase your insulin levels. So that's more or less in a nutshell on how it actually works. And then it also there's some studies that show it works on the brain, where it helps with cravings. Okay, so you've got cravings coming from the brain, then you've got your incretins in your stomach that's increased, making you feel fuller. It helps with the release of the insulin, and it helps the liver not to release that much of glucose. So when you look at your patient sitting in front of you, if you look at your diabetes patient, that is actually we've got we always say the first line of treatment is metformin. And that didn't really change over the years. The second line will depend on the patient. In the past, it was sulfonylureas. Now there's other drugs on the market. So it depends on what the patient's disease are. If they're a cardiovascular patient, you will add a SGLT first. And then if they're still struggling, and it's an overweight patient, especially if it's a diabetes overweight patient, you would like to add Ozempic because of the positive effects it's got on the body. Now, it is in America, you can use it for, in South Africa we use it off-label for weight loss, but not, it's registered in America for weight loss. So you've got it for weight loss, and then you've got it for your patients who are suffering from diabetes. We also can prescribe in latest studies, you will see that fatty liver syndrome that you do get. It's mostly a lifestyle type of disease that you get. Ozempic is one of the drugs that's been recommended now to try to treat those patients. So now we're coming back to overweight or obese patients. I need to make the listeners aware that diabetes is a prescribed minimum condition in the South African context. We call it a PMB, and it is recognized as a chronic disease. However, for the first time, obesity is now also recognized by the World Health Organization as a chronic disease. So if you then...
Can I come in there? So if obesity is recognized as a chronic disease, doesn't the question that needs to be answered that obesity in most cases is due to lifestyle? So if you perhaps change your lifestyle and you can get your weight and your health in order, you don't need to be on chronic medication just for obesity.
Okay, so now there is a trick there. So if your body mass index is, let's say, about 40, so we will start to think about Ozempic for weight loss in the normal surgery for around about 35, BMI of 35 and up. However, diabetes, their BMI can be lower. As I've said, it can be a third-line drug in trying to treat and bring that glucose under control. Now you're looking at a patient with a BMI of 40, 45. The literature is very clear on that. On the minority of people.
And BMI meaning body mass index. And how do people monitor or check their BMI?
It's your length as well as your weight. And then there's a formula that you work it out with. And if that formula shows that you are, let's use 40, 45, okay? It means you are obese. That patient trying to get his weight down by diet alone, the minority will get it right. And then the minority will be able to sustain it on a very, very strict diet. So the common treatment for patients with a high BMI would be to do that bariatric surgeries to try to help them.
That's extreme.
Well, unfortunately, if you are weighing, let's say, 150 kilograms, you are a diabetes, you are suffering from heart conditions, you have hypercholesterolemi, we need to get your weight down. You're not going to get it down by diet alone, or your chances are quite slim to get that right. So you need to produce or to give that patient another option. So bariatric surgery will be the option. And now with the Ozempic or semaglutide that's on the market, you've got another tool in your toolbox to try to help those patients. However, if you are, let's say, your BMI is 27, and you come to me and you say, I want Ozempic to be prescribed. You know, doctor, I'm just overweight. But you're actually not really overweight. You should be able, by diet, as you have mentioned, that patient should be, with diet, get their weight down and lifestyle. But not the patient who is 40 and above. It's really very, very difficult. And the medical scheme, some of them will pay for those bariatric surgeries, some of them won't. Also, again, leaving that patient without, who doesn't have money to go for surgery. Those surgeries is around about 150,000 Rand, very easily. So if you don't have that money, what do? You cannot just say to a patient, listen, you eat too much. It's not about what I eat. It's not about that. Once if your BMI is too high, a whole different scenario comes into play. So when we look at that Ozempic phase that you were talking about, that is patients who has lost a lot of weight in a very, very short time. And I'm not sure how much Ozempic you need to use to get that face, but I think you need to use a lot and not eating a lot either. So you lost a lot of weight, you lost the fat that is normal for your face as well. And that's why they look actually sick if you look at them.
Very gaunt,
Very
the face
gaunted,
is drawn.
Yeah, they don't look healthy. So that Ozempic face, it only tells me you didn't follow the rules and you were very strict with yourself when you started with Ozempic.
So what I do also want to dig into much further regarding Ozempic, and I know we're going to talk about the state of state hospitals a little later, time permitting. You spoke about bariatric surgery. That won't be an option at a state hospital, would it?
It will be, if you're lucky enough. Yeah, it is. It's available at the state hospitals, but it's difficult to get in there, and I think the criteria are very strict. And it's not for, they won't do it for each and everyone. I'm afraid, it's like kidney. If you need to get a kidney transplant or dialysis at a certain age group, they just cut you off and say, we don't have enough resources, we'd rather leave it and give it to younger people, it's got a better chance in life. So it is a problem, but bariatric surgery is at the public sector hospitals.
But it would be under very extreme circumstances,
yes.
Obviously.
Yes.
So why is there controversy around Ozempic? I spoke to a healthcare professional a little while ago. I'm going to put the question to you and you can respond right after the ad break. And he was up in arms about this whole situation, suggesting that people are buying up the supplies of Ozempic for weight loss, and the people who really need it, the people who are chronic diabetics, can't get their hands or can't afford the Ozempic. So there was an outcry from this healthcare practitioner. So let's talk about possibly that being the reason for the controversy around this, but right after the break. Dr. Angelique Coetzee, a GP from Pretoria, is in studio talking about Ozempic, and we do hope we'll be able to, by way of this interview, dismiss any misconceptions you have about this drug. Welcome back. Ozempic, the diabetic drug, which a lot of people are using for weight loss, is the topic of discussion today on Perspective with Dr. Angelique Coetzee. Stay with us. I gave you a question just before the ad break. The fact that because of the demand for Ozempic as a weight loss drug, people who really need it for diabetes is not able to get their hands on it.
Well, it is true that there's a demand for Ozempic, but it's worldwide. It's not only in South Africa. That's the first thing. The second thing is it doesn't bring the fact that there's a demand doesn't make the drug to be inferior or anything of that. So if you look in the South African context, there's no medical scheme that will just, as a third line, allow you to get Ozempic. You will have to motivate. Incidentally, I've just motivated to discovery for one of my patients, which I think would do extremely well on Ozempic as a third line drug. So we're still waiting for that outcomes. So they will most probably fund it what they would normally have funded, let's say an insulin or so, and the patient will have to pay out of pocket. So let's come back to people who needs it, can't get it. The problem is the medical schemes is in any case not going to prescribe it or to give it to you on your option that you are on. So even if you need it as a diabetes, you will also have to pay out of your pocket for it.
Almost like the difference
between what they
would pay and what you've got to pay.
Yes.
And that is because it's quite an expensive drug.
It is an expensive drug, but that whole class is expensive. So Ozempic is not the first one in that class. There's two other drugs in that class, of GLPs, and they are even more expensive than the low dosage of Ozempic. It's very interesting if you want to start to look. But they didn't have the same positive effects, the anti-inflammatory effects, the good effects of the Ozempic. And therefore, there was not a lot, you didn't hear a lot of that in the news. And Ozempic and the other drug that's also now on the South African market, tirzepatide, is the two that has shown quite good, significant weight loss. But remember the weight loss. Remember what I've said about the incretinins. It increases the incretinins. It increases your satiety feeling, your hunger feeling. It also makes you then that if you eat the wrong food and you're on Ozempic, you're going to get nauseous. In the beginning, there is side effects. There's 3 side effects that we see the most often would be nauseousness. They can have a diarrhea and then just not feeling well. That's supposed to go away. And again, if you look at weight loss with Ozempic, you're going to pay for that. Although obesity is a chronic disease, you're going to pay for that out of your pocket. If you are diabetic, you're also going to pay for that. And maybe that's where the problem is. We should, there's more people who are willing and desperate with a high BMI to pay out of pocket than maybe diabetes patients who can get a 3rd or a 4th drug on the medical scheme.
You talk about third-line drug. You referred to it just now. What does that mean in terms of the medical aid?
So that means I'm a diabetes patient. So I'm using, let's say, metformin. That is, we always say it's not really negotiable, except if you've got side effects from your metformin. Then your second drug might be the old sulfonylureas that's on the market, or you will use some of the SGLPs that I've talked about, or you might also be on an injectable, but still struggling. And now we're looking again at your BMI. We struggle to get you under control. We know if you can get you to lose weight, we can add Ozempic once a week, and that would most probably help you to lose your weight. Remember what I've said, it will increase your insulin, it will lessen your glucose production by the kidney as well. So that, and then again, then we come back to the inflammation. So inflammation in the body is a very important thing. So once if you are diabetes and you have got high blood pressure or cholesterol and your inflammation markers are elevated, you are at risk. You are at risk for stroke, you are at risk for cardiovascular diseases, you are even at risk for dementia. And there's studies now out there showing that it's got a positive effect on dementia in some of the studies that's now out. We also see the positive effects on some of the cardiovascular components that you can get, especially if you can compare that with what we call an SGLT. That's great drugs to use. Unfortunately, again, both of them, even the SGLTs, the medical schemes are paying now for that, but they are also expensive. But what's the cost? Whether you are a diabetes that's uncontrolled, or whether you are someone with a BMI of 50, it's just as heartbreaking to see both of them. I'm not for Ozempic, as I've said, for someone with a sort of an acceptable, they're a bit overweight. They should not take that. They should not.
Off air just now, you said to me, and I was pretty surprised when you made that comment, that Ozempic is a good drug and it does have a lot of positive effects. Yeah. What are the side effects then? Because surely when you start taking Ozempic and you've lost, you reach your goal weight, does that mean you continue with it? That's a very expensive exercise. And if you continue with it, is that going to then continue making you lose weight so dramatically that you won't look like your old self at all?
So if you start taking, let's say we're not talking about diabetes, we're not talking about
weight loss. Yes.
So if we prescribe, let's say I'm now obese, I'm starting to take Ozempic, we normally would go up to around about 0.5 milligrams once a week for that patient. You start on 0.25 for about 4 weeks. That is to lessen those nauseousness and the side effects. Yes, you can get hepatitis. Hepatitis is not the right term. You can get inflammation of the liver or the pancreas. You might lose some of your bone density, and you might get that phase that we have talked about. But then again, if you lose your bone density, if you want to lose weight, you should follow also a healthy diet and lifestyle. In that include just walking every day. So you cannot just depend on an injectable to make you lose weight. You have to work as well. You have to make sure that you at least do your exercises or walk, even if you can walk 1 hour per day, that's more than enough. That will prevent your bone density, loss of bone density, if you can do that. If you make sure that you eat right, your nauseousness would also lessen a lot. We have seen that if they eat a lot of rich carbs, it makes them nauseous. And I'm always laughing and say, you didn't follow your diet if you come and complain to me.
So let me ask you this question. I think this is very important. If you're on Ozempic, are you suggesting that even though you will lose weight pretty rapidly, is that in conjunction with a healthy eating style? Or are there people out there who think I need to lose 20 kgs, I can do it in 6 months or a year, and I can still continue eating as I've always done in the past?
Well, then you should not be on Ozempic. Then you deserve to be where you are. Because if you want to lose weight, Ozempic is one of the tools that we know is going to assist and be beneficial to you. Not only to lose weight, it's still going to be beneficial on your heart, still going to be beneficial on your sugar, on your kidneys, on your brain.
Even though you're not a diabetic patient?
Even though you're not a diabetic patient. So there's really a lot of positive things on Ozempic. And as with any drug, as I've said, there are side effects. There's also the eye complaint, or not complaint, there's a bit of a concern around certain people who might get blindness in their eye, one of the eyes. Again, the studies is ongoing there. It's not 100% proven, but it's in a minority, again, of patients. That, the face, the bone density, and the nauseousness that you can get is at this stage the most common side effects that we need to be aware of. So if I'm taking Ozempic and I'm losing weight and I'm walking every day and I've tried to stick to my diet and I reached my goal, you then need to see, do I then need Ozempic to keep, remember, obesity is a chronic disease, to maintain my weight? And what dosage do I need to take? Can I go to a lower dosage to maintain my BMI or my weight? Or do I need to stop it? And can I then stop and then maintain my weight?
But I should imagine, Dr. Angelique, all of those suggestions that you're making now on air is going to be manageable only if you do it under supervision of your GP.
Yeah, that's, you need to be with, so it's not only your GP, it's actually a team. So what we do in our surgery, we make use of a dietitian as well. So we first send now we're talking weight loss patients. We first send them to the dietitian, so we want to know, what is their body, body water, the body mass, the muscle, and the fat, and all of that. We need to know. They need to be explained what is a healthy lifestyle and what do you need to do. Then we give them about 6 weeks or so, and if they don't or they struggle, a good weight loss is around about 1.5 kilos per week. So if they struggle and they don't lose weight, we then bring in the Ozempic and see if it's got a positive effect. Most of the times it's got a positive effect. If you struggle and you try, and that's what I've said right in the beginning, people think it's only what you eat, but it's a chronic disease as well. So you can eat very, very superstitiously the correct stuff, but you're still not losing, you're losing 0.5 kilograms. And it's heartbreaking to see sometimes these patients, they say, doctor, I didn't cook, I tried my best. That's the patient that you bring your Ozempic with.
Okay, let's go for that final break and we will wrap up on some more important questions regarding Ozempic and weight loss. Welcome back. We are talking with Dr. Angelique Coetzee. We're talking Ozempic, we're talking weight loss, we're talking maintenance plan, we're talking side effects, and we're talking about all of the pros of Ozempic. And Dr. Coetzee is pro Ozempic, even for weight loss. What happens to a patient who abuses the drug? You prescribe an X amount on a weekly basis, and because that patient is so desperate, they double the dosage, meaning they lose double the amount of weight that they would have lost. At what risk are they doing that in terms of their health? And then when you examine a patient, what sort of comorbidities do you look out for and decide that this patient is or is not a candidate to go on the Ozempic program?
Julie, that's a very important question as well. So let's say you abuse your Ozempic. Then I would like to say you're definitely an upper class person, because it's going to cost you a lot of money. You're then looking around about 3,000-4,000 rand a month. That's quite a lot of money. That's the first thing. The second thing is you're definitely going to get the loss of your bone density. More brittle, you can easier fall and break a hip if you're not young anymore. You run the risk of pancreatitis. You run the risk of that severe nauseousness and feel generally not okay because you're not sticking to the rules. You will have that face that we have talked about. Instead of everyone thinking you look so great after you've lost weight, actually looking like a ghost. Then also, you've mentioned it before, the flabby skin. You will sit with that flabby skin, and it's very difficult to get rid without cosmetic surgery of those flabby skin. So as in anything, if you want to lose weight, you need to do it controlled. You need to be part of a team, a doctor, a dietitian, even if you can get a biopsychogeneticist to try to help and make sure that you do it the right way. Your weight didn't come overnight. It comes over the years. So you also need to make sure and say, listen, I've got a year plan. This is where I want in a year later, and it should be realistic, and we all need to agree with you on that plan. So I'm not a diabetes patient, so I want to lose weight. So what are the other risk factors that we would look at? We would look at, again, if you are morbid obese, your BMI is 50 and more, we know that you are really in need of either bariatric surgery or start a course with Ozempic, and again, under the supervision of a team. From there on, we would also look at high blood pressure. So if you are a hypertension patient, and you're also not very well controlled. Remember, the more your weight, the more difficult it is to control your hypertension. We know you are at risk of a stroke, you are at risk of hypertension, of cardiovascular diseases, especially if it runs in your family. If it runs in your family to be a diabetes and you're not yet a diabetes with that weight, you've got a big chance to start to that. So you look at the comorbidities, you look at the whole picture of that patient. And that's the type of patients that I'm really in favor of. I'm not in favor of someone who's a BMI of 28 or 27. That is proper lifestyle. You can do it. You can lose. It's about 5 or 6 kilograms. You can lose it, and you can learn how to eat correct in that setup. Because by definition, once your BMI is above 40, it is not only food. It's a chronic disease.
Let's look at the issue around a patient who comes to you, and together with the multidisciplinary team, you set them off on this wonderful program, Ozempic, lifestyle, walking, etc., etc. They reach their goal weight. Let's assume this is someone that is quite obese, and they reach their goal weight at the end of the year. they still, despite the fact that they're being supported by other medical health professionals, they are still going to sit with the issue of a flabby skin. How do they deal with that? That's not going to go away, and that's not going to make them look good. Is the alternate or the only thing available to them plastic surgery?
So if you, again, plan with your team that your weight loss per week is not 10 kilograms, or your goal is not 5 kilograms per week. If your goal is realistic, then the flabby skin should be less.
But still there.
It will still be there. But if you lose a lot of weight because, you've got an obsession or whatever the reason is, unfortunately, there is not really other, you can wear a stepping or you can wear anything else that try to minimize the effect under your clothes of your loose skin. But it's very, very difficult to get rid of that loose skin without surgery. Now you sit with a second problem that most of the medical aids will see that as cosmetic. And again, you'll have to pay most probably out of your pocket to get rid of that flabby skin. So do it moderate. Don't go in excess. Don't, again, as I've said, look after your health. Also remember, weight, I'm not talking about a little overweight, I'm now talking about real obese people. It's a chronic disease. You will most probably for the rest of your life need supervision or need to be on something to try to help you, as is diabetes, as is hypertension. You cannot, once if you reach your goal with hypertension, blood pressure is under control, your diabetes is under control, now going to say, now I'm going to stop all my medication, I'm now under control. It's still, you still need to follow the rules, you can't eat what you want, you still need, it's a lifestyle for the rest of your life.
So you start a patient who's obese on Ozempic. They reach their goal weight by end of year 1 or end of year 2. Does that mean they stop taking the Ozempic? Because obviously you're talking about a chronic condition. Or does that mean they're going to have to take the drug for the rest of their life? And is that going to add to the costs of upkeep?
That's going to add to the cost of upkeep. The majority, of course, it's a chronic disease. It's a chronic condition. You will need to look what you eat, and if you then can't maintain it, you'll have to use a low dosage of Ozempic, because you want that incretin to be elevated, you want your insulin to be elevated to try to help your body to get rid of those insulin resistance type of thing that you do get that keeps on, that keeps you on gaining weight after you have stopped. Again, it's the same, that's why I keep on emphasizing it's a chronic disease, like diabetes, like hypertension. Once you reach your goal on any of your chronic diseases, with medication, you can't actually stop the medication. You can bring the dosages down. Dramatically and see what is the minimum dosage that can still help you maintain. So maybe you can get away with 0.25 milligrams of Ozempic, meaning instead of 1 month, and one syringe would last you 2 months, and that half your costs. But you can only do that once if you have reached your goal. Then you can say, and see what I'm doing. There will be people who's lucky, and they stop their medication and they still keep on with the exercise, they're walking, the good diet restrictions that they are following, and they're fine. But I need to make sure that people understand it's a chronic disease. It's not to say once you reach that you're going to go.
Okay, so this is the wonder weight loss drug, but there are strings attached. Yeah. There is lifestyle changes, there's lots of monitoring, and even before you go onto the drug, best that you consult with your doctor and then work out a plan. I can't go into a pharmacy and buy it over the counter, can I?
Well, with an ethical pharmacist, you might probably get away with it, but it's not the right thing to do. It is, you know, if you really are serious about your health, do it the right way. There are better drugs going to come onto the market than Ozempic, so I need to I need to make people aware. So if you think Ozempic is now good, there's still a lot better ones in the pipeline. But again, it's going to bring us back to that same point. You know, how quick do you want to lose weight? And what are you willing to sacrifice? And I don't think you should sacrifice your health. I think you need to do it controlled, not using counterfeit Ozempics that's on the market. If it's not saying Ozempic, it's not Ozempic.
So you're saying there's counterfeit drugs on the market suggesting that it's a generic and it's going to work as well as Ozempic. How would I know, an ordinary lay person, if I go into the chemist and I bypass you, my medical practitioner, to go and buy the Ozempic or the counterfeit or the generic, supposedly in my mind, to get me started? How will I know what it is that I'm ingesting and whether it's good or bad for my health?
For now, there's only one drug. I'm not talking about tirogliptide. I'm talking about Ozempic, semaglutide. There's only one drug on the market that's been approved by SAHPRA, and that's Ozempic. So if it doesn't say Ozempic on the label, if it doesn't say Ozempic on the syringe, it's not Ozempic. So I can also not tell you what you're getting.
That's all we have time for. So we are ending on a note of very good news. Final thoughts from you, but sharp and short.
Look after your health. Remember, a high BMI, difficult to lose weight. And do it right. Do it in a team.
Dr. Angelique Coetzee, thank you indeed for your insights on this matter. I know lots of people out there were wanting to watch this interview and wanting to hear what you have to say about Ozempic. So there you have it, lots of good news, positives on Ozempic, but you need to do it in conjunction with your GP. Have all the necessary tests done. I should imagine you'd even have to undergo a bone density test, because if you have brittle bones, then this ain't for you, because you're going to have multiple falls and multiple fractures. That's all we have time for. Thank you indeed for your interest in the show today. Till you and I get together again, till the next time, as always, Khuda Hafiz.